Okay, great. Okay, so I was wondering if first, just to kind of open it up with a super broad question, if you could kind of tell us about like what got you interested in the work that you currently do, and what drives you to work within your community to improve health outcomes.
All right. Well, so excited to be here. And so I'm a medical sociologist, and I have my bachelor's in marketing and a master's in theology. And part of that has shaped the reason why I'm doing what I'm doing now. It's all come together. When I grew up, I'm from Arkansas. When I grew up, there were a couple of things that alarmed me. And I think the most important thing was that there were people that I really loved, my grandmother and aunties, that died too soon. And they died of either diabetes or heart disease. And I was trying to figure out, why is it that they sort of pass before the deadline, as some people would say. And then, so, that was just a question. But I decided, okay, I'm just going to go to school, go into marketing. And then while I was an undergrad and, thinking I would become a businessman, I decided to go into ministry. So I graduated early, went to get my divinity degree, and then was really active in my church. And I realized that the same thing that existed in my hometown in Arkansas existed even in college. When I was in Houston and in DC, there were people that seemingly died too early. And most commonly was from heart disease or diabetes or anything related to that. So I decided to try to figure it out. What is it that, people are, what's happening to preempt this? So I just thought that, people get sick before they get to the hospital, and there's something that's in society that's making them sick. And so I decided to look at some of the social determinants of health, which you probably have heard, and how that impacts one's cardiovascular disease. So it's not necessarily only about what a person eats, how a person exercises, but it could be some other factors that contribute to that. And so all of that has sort of, it was personal to me, my passion, and because I'm so involved in the community, even in San Francisco, I see the same things. And so I'm trying to figure out what can be done to address some of those issues. And I think from my perspective as a medical sociologist, it's society that contributes to one's detriment to health in terms of their health. And so that's sort of my passion, has been to understand what in society that I can sort of help or advocate for to ensure that people live longer. Because we all want to live longer. Not only do we want to live longer, we want to live a quality life. And so that's been the goal for me, to help people live a long quality life.
Yeah, that's an amazing goal. And you said you spoke a little bit about how the problems that people have with their cardiovascular health are more than just like exercise and their diets. So I was wondering, going off of that, if you could speak to like which institutions the United States have the largest effects on Black Americans' cardiovascular health as a whole. And I know that's like a super broad, open-ended question, but just like in the work that you've done, like I guess which institutions have like the largest impact?
Well, I think I guess I'll answer the question by education is the key, right? So the institution in terms of education and opportunities for young people certainly is the key in terms of some of the barriers that prevent one from having the optimal health that they need. A lot of people just not getting educational opportunities. And we know that leads to economic opportunities. So I think it's certainly important. And then just generally, I mean, like it's the government, like there's policies that can be in place to ensure that those that are disadvantaged get the opportunities and things that they need to live a better life. And so I think those will be the two sort of institutions, if you will, that I think they're certainly important. Obviously, government is sort of that overarching sort of institution that because of the policies that can be in place to ensure that people, have access and opportunities. That's certainly important, but education for me is the key. And then, sort of just like a side note to that is that the work has to be what we call in our field pipeline work. Or life course work, if you will. So you have to really look at from the woman that's actually pregnant with child all the way up to development through their childhood, adolescence, young adult, and senior age. And so that's when you look at health, you have to really start with sort of the woman who's conceiving. So we can talk a little bit more about that, I guess.
Yeah, the next question was going to be to specifically ask about the social determinants that are like, I guess, within the institutions that you had mentioned that would affect that sort of like pipeline, like life course work that you were talking about.
Mm-hmm. When we talk about social determinants, we talk about things like poverty. We talk about things like incarceration. We talk about things like violence, environmental exposures, or lack of access to healthcare. We talk about things like socioeconomic status. And one thing that what I do in terms of social determinants is I look at actually this concept called adversity, which you can define it as psychosocial stress. And so a lot of the social determinants that we deal with are stressful. And so when we look at social determinants, for example, I talked about economic opportunities, or social economics is how we sort of name it. That's stressful. Financial stress is a real deal, right? And so work stress, not having the job that will provide your family with the resources that they need, that's certainly stressful. Access to care. So if a person is not able to gain access to healthcare, certainly stressful. And that leads to a lot of the comorbidities that people have, such as obesity and diabetes, which we'll probably most likely talk about later. And then there are other things like discrimination, racism. That is a social determinant of health, if you will, or discrimination at least. Unemployment, underemployment, part-time workers, seasonal workers, all that contributes to sort of health outcomes. And then just your neighborhood, where you live, your zip code has everything to do with your health status. And so when we talk about social determinants, it's everything that people experience on a day-to-day basis. And when you put it all together, it's really, so what I'm sort of studying is how that all impacts one's health in terms of the stress that as a consequence of those determinants. And so when I look at stress, I don't look at, a lot of the research only focuses on one's perception of the stressor. And so when you think about research and, they say, obviously stress leads to bad health, they're only focusing on one stressor, like caregiving, like work stress, only financial stress. But my work deals with a combination of stressors, those stressors combined, because people just don't have financial stress. They have financial stress, they have work stress, they have neighborhood stress, they have this work family balance stress, and they experience discrimination. So all those things combined actually contributes to even greater or sort of worser health outcomes, particularly cardiovascular health. So I've sort of went around, but it's certainly the social determinants is obviously those things that impact us that's unrelated to just the biology, but looks beyond that.
And you had mentioned something about like the zip code that you live in. So I was wondering if you could expand on that, and specifically regarding food deserts and how they disproportionately impact Black Americans and their cardiovascular health. Because I know that, like, I think it's like it's common knowledge that Black Americans are most affected by food deserts. So yeah, I was wondering if you could speak to that.
Sure. So I live in San Francisco, and there's a There's an area in San Francisco called the Bayview Hunters Point District. It's a primarily, actually, it's it, it's it has predominantly been African Americans historically. Now, because of gentrification, African Americans are migrating to other places, but now it's the large portion of African Americans are there. There are only 2 grocery stores there, and the grocery stores that are there have low quality produce, and so certainly the zip code, and there's been a lot of work on this, that, your zip code determines your health status. You asked a question about food desert. So I think the food desert doesn't really open the conversation that we need when it comes to race. Okay. So when we talk about food deserts, I think we should shift that conversation, because the word desert, it seems as if the communities are lacking when they are filled with life and resilience. Okay. So I want to change the question to really talk about food apartheid, because food apartheid, it brings this sort of the reason why people don't have this access to food is primarily because of a system that has sort of created this through, whether it be redlining, et cetera, that created this, the lack of access to food for certain people. Because this is a reality across the country, right? So it's just not this, food desert here, but it is a system. And that's what really, when we talk about, especially when I talk about sociology, medical sociology, I'm sort of shifting sort of the language and how we see things, as if, just as, for example, when we talk about vaccine hesitancy, as if the person is hesitant about the vaccine, but it's the system that has created a history, a dark past of the exploitation of medical research. And so when we talk about food apartheid, it certainly results in policies such as redlining, which has resulted in low access to healthy foods, particularly in Black and brown communities. And if we look at food insecurity simply as a geographic issue, we certainly are missing the mark. We have to acknowledge the ways in which racism and white supremacy sort of permeate through each layer of the food system in order to truly be, to build equitable communities. So that's something that I certainly wanted to highlight in terms of food security. And then the other thing is, this is certainly near and dear to my heart, because as we've experienced COVID, food insecurity has heightened, obviously. And, it's heightened in the economic depression in 2018 or 2008 rather. And now we should assume that is certainly heightened in a greater way because of COVID pandemic. So what I've been doing is actually feeding people since the pandemic. So I've been partnering with churches in the area to provide meals to particularly seniors and also families with children, because people don't have food, that is in essence that, you take away a person's dignity basically when they don't have healthy foods. And so since March, we've actually provided 220,000 meals to folks on a daily basis. And this is quality and prepared meals. Because that impacts not only their physical health, but also their mental health and ultimately the cardiovascular. So a lot of times when we talk about cardiovascular disease in the heart, we know that diet is a major component of it. And we know that, folks don't have access to the proper nutrition. And so this was our way of making sure that at least they got that basic necessity, and that it was quality food that they were able to not only sustain themselves, but their families as well. So we've been able to get some great donors to provide that opportunity. So the COVID pandemic has opened up possibilities of what folks with the resources can in fact do, right? And so then hopefully this work will be sustained.
So we have a question about COVID, but while you were talking, I had another question that I just thought of. So I know that there are a lot of studies that that directly link trauma from racism and hypertension. And I was wondering if you've done any research in that, or if you've seen I guess the effects of that in your work.
Certainly. So when you talk about, so there's racism, trauma. So racism, as we know, there's levels to it, right? So there's first is the institutionalized racism, the racism that we get from the barriers that we talked about, and then there's the sort of personally mediated racism, which is intentional. Sometimes it's unintentional. And then you have internal racism where, I may experience racism and because of that, feel that I am less than, feel that I'm inadequate. So those are the internalized racism. So all of those levels sort of obviously is directly impacts not only your cardiovascular health, but risk, and also some of those sort of what we call biological endpoints. So a lot of this work is found in David Williams, and I can sort of share with you. He has this scale. It's called the Everyday Discrimination Scale that he uses. It's a scale that he uses widely, and it has been that scale that has been used to determine whether or not things like discrimination impacts your weight. For example, there's a study that he did with Black women. It was about 43,000 Black women, and they were aged about 21 to 69, and there was 8 questions about their perceptions and their experiences with racism, and they used this everyday discrimination scale that was that David Williams has provided. And that study suggested that weight gain increased as one's levels of everyday and lifetime discrimination or racism increased. And so, that is one of many studies. So some that link racism to weight gain, as we suggested, and also incident cardiovascular health. There's been studies that linked discrimination to sleep, which sleep is also a risk factor for cardiovascular health. And so, there's tons of data that suggests that discrimination, racism, and one's even perception of it. So I think that's important. You may not, and that's all that matters really, is your perception of being discriminated against or having some sort of experience with racism. That in fact impacts your cardiovascular, not only the disease itself, the coronary artery disease, but also weight gain and hypertension and diabetes and all those. You talked about racism and trauma, but those things combined, right, is certainly what I'm looking at. So I've done studies that looked at stress, those things like discrimination, work stress that I mentioned, financial stress, those things combined, and its impact on diabetes. And so what I found is that those who had higher levels of those combinations of stressors through time had they were 2 times more likely to have diabetes than those that did not. Okay. And then the other study I did was the same thing as on negative life experiences, traumatic life experiences, and its relationship to obesity. And in terms of the traumatic life experiences, they were certainly 14% more, had a higher odds of being obese than those that didn't have any traumatic experiences. So, there's tons of data out there that suggests that certainly there's, discrimination and its impact on one's health. But this concept that I'm trying to drive is this combination of trauma and stressors that impacts one's health. And we've had colleagues that have also looked at this as well. And there's certainly a correlation.
Thank you so much. Yeah, all of that That's that's very interesting. So then going back to COVID, so this is again a really broad question, but just in terms of your work, if you could talk about what you see is the current status of cardiovascular health amongst Black Americans currently, and you mentioned it a little bit with food insecurity, but how has COVID-19 impacted it? Um, yeah.
Yeah, so I think just to step back and give us maybe an understanding about, heart disease is the number one killer, right? But in COVID, obviously, it's become the number two, but certainly it is the number one killer. So African Americans, particularly, are 30% more likely to have heart disease than whites. Okay, and this was data, and the latest data was in 2018, and then in terms of African American women are 60% more likely to have high blood pressure, which is a major risk factor to heart disease than white women. So I just wanted to start there that it is certainly a number one killer for everybody, but it's certainly heightened in terms of African Americans, Native Americans as well. And so as it relates to COVID, as you probably know, that those who have comorbidities have worse experiences with COVID than those that don't. And some of those comorbidities are the same risk factors that we find in those who potentially will have heart disease. So for example, like hypertension, like diabetes, smoking is a risk factor, sleep is a risk factor for cardiovascular disease, cholesterol levels, blood pressure. So and hypertension is the same thing. But those, in fact, have always been an issue with African Americans. And so as COVID hit, that's the reason why African Americans are like 2 times more likely to die from COVID as opposed to any other groups, and almost 3 times more likely to actually be hospitalized, because we've already experienced those risk factors like diabetes, smoking, hypertension, et cetera. And so then when we talk about the conversation that we've had previously, what contributes to all the high blood pressure, the diabetes? Well, it's the social determinants. Okay. And so that's the thing that we certainly should address, because we know now, if we've never known before, but a lot of people have known or been trying to explain that when we get into another crisis, like a pandemic, Black folks, those that have been sort of a disadvantage, will always have a more or higher rates of mortality, because we haven't really addressed the social determinants. The reason why they have these comorbidities, it's not simply because they don't eat right. It's not simply because they don't exercise. It's because they don't have access to a neighborhood that makes it safe for them to exercise, or a neighborhood that provides the high quality grocery produce that's needed to have a healthy diet. And they are experiencing, lack of access in terms of education, in terms of their kids and adults. And then they're experiencing the stress at work. All these things is going on, right? And it's contributing to this issue, these comorbidities. And so, what we found even in the pandemic is that now you can say it's that times 5. Okay. And so now it's almost as if, we have, any progress that we have made is, we're sort of backpedaling, but we're hopeful now that there will be organizations and donors that will provide the resources that's needed to address these issues.
And another question, I guess, regarding like racism in American healthcare, in general. I guess, what role do clinicians play in the cardiovascular health statuses and also outcomes of Black Americans? And I guess like asking about the impact of racism in American medicine is just literally books can be filled with that. But I was wondering, like, in terms of the history of racism, how has that contributed to like access of care, and also like I guess just like the ability to get treatment as well?
Yeah, well, just an example of that, there's several studies out there that certainly look at discrimination in the healthcare, and that that even physicians perceive blacks to be or to be able to accept pain more. So their likelihood of providing them with any other some drug to sort of eliminate some of the pain is less likely. So there's always this perception from physicians. So I think what's most important, and I guess this is sort of what I want to highlight, is that there's a, and this is for us all, that there's a need for education, particularly in healthcare and around specifically around, and physicians. I think it's important for them to understand the social determinants of health, and so that's certainly what I've been trying to encourage. And I think that we're actually making some progress. And it goes back to my statement, is that before people get into the hospital, they're sick. And so you have to determine, what is it that is making them sick outside of the hospital? And a lot of physicians aren't well versed in the social determinants of health, to be honest. And so one of the things that needs to happen is creating sort of a losing my train of thought, but multidisciplinary approaches. So, for example, a sociologist needs to be a part of a medical school, or needs to be a part of this, physician medical team, so that they can understand the importance of looking at the fact that if you give this patient medication, they're not going to get it because they have to, first of all, they don't have the transportation needed. But then second of all, they would rather spend money on food to feed their families to get medication to take care of themselves. So those dynamics have been missing. And I think physicians are learning that, but that all stems from, what they've been taught, what they've experienced in terms of, what they've been taught in medical school. And a lot of this work on social determinants and racism and discrimination have not been taught. And so now, you'll see many institutions have now a diversity inclusion sort of department. And now there's more attention to social determinants. And I think what needs to also happen is there needs to be those that are in leadership that actually understand, because that's certainly what it takes. And as an example of that, my mentor, Michelle Albert, whom you all have invited, she's actually, it should be on the press now, she's the next American Heart Association president. And she gets the social determinants of health. That's her whole point as well. And so her being in leadership will give rise to these things so that it can, hopefully bring on more sociologists, more public health professionals into the cardiovascular space to help to understand the importance and the role of social determinants on cardiovascular disease. Because to be honest, a lot of physicians may not feel it as important. And so this is a way to bring into conversation these things that's needed.
Yeah, I completely agree. The lack of holistic education present in American medical schools is astounding. And I guess what are other next steps that you would see that you see as the future of the work that you're doing in improving heart health outcomes for Black Americans, and I guess breaking down these barriers?
Yeah, well, it goes again to addressing the social determinants. So expanding housing for people, providing food for people, giving people access to the health care, supporting education from a life course perspective, improving, as we've known in the pandemic, many people don't have access to the technology that they need to actually thrive during this time. So, and then we've learned also about the importance of collaboration and partnership. So this sort of academic community partnership is necessary to address the needs of the community. And if that's our main mission, which it should be, to ensure that people live quality lives, we have to actually, as academicians, we have to collaborate with community partners in order to do this work. And that's certainly some things that I've been doing. And then there's also, of course, policy implications for this. So for example, I am no longer, but have been the co-chair of our soda tax legislation that passed through the city of San Francisco. I'm the co-chair of that committee. So the taxes from folks buying or purchasing soda, we were able to raise money from that and then put that money back into the communities. And so this is an example of policy and how it works in terms of impacting communities. So this committee, from each year, the city generates about $1.4 million. And from that, the committee decides on how that money is used. And obviously there's folks like me that understand social determinants of health. So I'm advocating for putting that money into, obviously, like the schools, providing food to people. So during COVID, we were able to redirect our funds to food security. And we were able to put in, I think it was about $1.4 million to food security in communities that's mostly impacted by the COVID. So Blacks, Asians, the Latinx community. And so that's just one of the ways where, policy that has been, made, there's legislation that's been passed, money is now generated, and then, you sit on these committees to make sure that it's going into the right place. And without that, we would not have been able to feed so many folks. And this is just not the folks that are affiliated with me, but this is across the city. We were able to feed a lot of people. So I think, and so then we all are also prioritizing workforce development. So providing resources for K through 12, who well, actually it's junior high through college, who's interested in sort of becoming a health professional, providing them with programs and resources to ensure that pipeline is there for them. So I think those are some of the solutions. That certainly it's about understanding the importance of social determinants of health, and then making sure that you're in places and where you can make decisions to actually address that. And one thing you can do is be an advocate for policy, and then sit at the table to ensure that those things are implemented. So that, that's one thing. And the other thing is, from the science perspective, are interventions, which Dr. Albert and myself are working on an intervention looking at social determinants, where we're partnering with the YMCA, which I remember talking to you about the importance of academic and community partnerships. They have a diabetes prevention program, which is it's a national program that's known to ensure that people either lose weight or maintain their weight. It's been proven, but it's not so much the case in Black and Brown communities. So what we've decided to do is say, hey, it's not in this diabetes prevention program. It really focuses on physical activity and diet, and it's about a community, actually doing this work together. But it doesn't work as effectively for Black and Brown communities. So we've decided to incorporate another arm of the study, and so that folks will get the diabetes prevention program in both arms. So there are two groups, but one group will get a what we call a job readiness service. So it's a case management service that provides them with the resources that they need to obtain a job. Because our idea is, it's not just, again, the diet and the exercise, but again, it's the stress, right? And so if one is able to at least be prepared for a job, to be ready for a job, that when they apply, they can get it through the resources, that it lowers their stress levels. That's our idea, right? That especially financial stress, which is a huge component to, like, out of all the stressors, that's probably the number one stressor that drives cardiovascular health. So we want to determine if those that actually get the job readiness services plus the DPP, will they be more likely to lose weight or maintain their weight than those that just have DPP alone. And so that is sort of the intervention that looks at social determinants. So, because it's really not all about just writing, right? It's not about just doing research for the sake of research, it's how we apply it. And we always end our writing with, you know, policy implications or intervention implications, but nobody actually does those. And so this is our opportunity to actually do something that, you know, that we don't know if it works or not, but no one's done it to actually see. So this is our opportunity of doing that. So I think interventions, policy, certainly two important things that you want to get to in terms of this research. You can't always talk about it. You got to actually do something. And so this is the way you do it.
Thank you so much for that response. The work that you're doing is absolutely incredible. And we have so much to learn from you. But those are all the questions that we have prepared. And I am going to open it up for audience questions now. And if anyone wants to ask a question, just go ahead and unmute yourself or like type it in the chat.
I actually have two questions. So my first question is, I find it really interesting when you were talking about the different types of racism that that people can face, especially internalized racism. So I was wondering if, although not the solution, what are ways that we can change that on an individual basis? And in your opinion, if there is one stressor that you would say had the greatest impact on Black Americans, which one would it be?
So the last question, that's a hard question to answer. I would guess it's financial stress, just based on the work that we know is that out of all the stressors, the work that looks at financial stress has the most impact in terms of cardiovascular disease. So I would say that for certain. And then in terms of ways you can sort of address those things like and so institutional racism it takes a lot to address that, right? To sort of get at systemic barriers, and it takes an entire conversation on how to address that. As a sociologist, obviously there are ways in which you do that through policies, or you just let it happen, you just let it stay where it is, or some that would be a little bit progressive, would say, okay, let's get rid of the system and build it back. Okay, so those are three options, and you have to figure out where you fall in line. Or you could just, you know, and it's up to you. But that's a lot harder to address. But I think in addressing internalized racism, and really all of them, I think the first step is consciousness, and, you know, educating yourself on these three levels of racism, and seeing where sort of your faults are in terms of this, and we all have those. And then I think it's important for you, after you've been educated, to have discussions among your peers about it. I mean, that's certainly sort of the first couple of steps that you need to certainly make. And I think, and that's important for all of us to do. Is there books that I can tell you to read, certainly to understand, I think, and you have to really go deep, and it's just a matter of how deep you want to go. And it really starts with, enslavement and understanding the impact that has even to generations following. So even myself, as a consequence of enslavement, like my last name is the last name of a slave owner. I don't know my last name. Every time that I say my last name, it's from a slave owner in South Carolina. Okay, so those things have implications. And so I think that it's important to certainly educate yourself, not only on issues of racism, et cetera, but really understand your own history and your background. And I think once you get an understanding of your own history, then you will have a greater appreciation of how to actually achieve these things that you seek. So I think that's certainly important to do. And then holding people accountable when things come up is the next phase. That don't be afraid to call out things, because you're now educated yourself. I think it's certainly important to ensure that others are or at least recognize where their faults could be, and guiding them through a process of trying to, you know, be a productive and a good citizen. You know? Thanks for those questions.
Thank you for your response, Dr. Butler. Does anyone else have any questions?
Yeah, thank you so much. This is all so interesting. So I know you mentioned earlier how you're trying to kind of change the way that people talk about certain things in the medical world, and take that like sociological or like psychological approach to it. I'd love to hear more about like any work that you've done, like maybe with medical students or with any like health systems. I just think it's so interesting. I've never really thought about the language that we use and how we shift that.
Mm-hmm. Well, I think it's more about visibility. When I say that, I was privileged to be a sociologist in a cardiology division. So I didn't necessarily have to, that was a big step. And so then people, because I was, I'm certainly a Black male, but when you talk about the diversity of your discipline, people begin to really try to find out, like, who is this? And so then, so now I'm in a different department. I'm in family and community medicine. These are family docs that have a better understanding. But again, there's only 2 sociologists there. So I'm certainly visible. So I need to make sure that the work that I do, that people see it. Okay. And then you have allies that will also understand the importance of the work. Then they sort of put you out in front of the university. So now I have like this university stage. And so now my work, particularly as it relates to COVID, because of my work in the community, people are noticing, they're recognizing. Because of the SDDTAC work and me providing the resources to address food security, people are recognizing. And when you see, you're not able to see change, but you're certainly able to see that there can be some implications for better health outcomes for community, just based on understanding those social determinants like food and being a part of policy, et cetera. So the work that I've been doing has been seen. So it's been visible to those folks that may not have appreciated sort of this sociology and health work. So that's the first step. And then it's about showing that you can actually make impact in community. So I've only been to San Francisco for 5 years. And a lot of the doctors who've been here for 20 years have been trying to impact, community, have been trying to do work in the community, have been trying to actually work in the community, but haven't been able to do that. And that's because of, them not understanding some of the things that a sociologist can understand. And so when they see you actually do that work, then they pay attention. And then when you're able to like do these things like this, this intervention that I talked to you about, and actually, this is actually a behavioral clinical trial, the first of its kind, being funded by the American Heart Association. When they see things like that, then they'll pay attention, right? And when you've proved to them that, even if doesn't matter what the outcome is of that, but if I'm able to do the science effectively, and I think that's all that matters. And I think because of that, you get even if they still don't understand it or don't want to understand it, they certainly have to appreciate it. And so I think visibility is certainly key. And then I forgot what your question was, but visibility was key. And then also ensuring that, the work that I do, I have to certainly build relationship in the community to do this work. So I think that's certainly important as well.
Thank you.
And then We have a question from the chat. So last year, a House committee introduced a bill addressing the disproportionate rates of cardiovascular disease and diabetes amongst Black women in the United States, and called on Congress to recognize it as a problem. And we were wondering if policies like this need to be amplified this year, or if they need to be changed to address the new impact of COVID, or like new research. So I guess like just more wondering like what you think more concrete actions that Congress needs to take to address these issues are.
All right. So the first thing is we've done enough research. We know the problem. That's the first thing I want to say, that we certainly know the problem. And I think what happens is in the research world, remember, it's institutionalized racism, right? So it creates a system that thinks that we need more research and we never get things done. And then the other thing that I would say is that, and so does that mean that research isn't important? There is some research that's certainly important. The research that's most important is the research that can be applied, okay? Instead of just doing it for the sake of one's promotion on their job. So to your second question about, the government is good for some things. The government is also bad for some things. And just to say that we want this issue or we are amplifying this issue doesn't necessarily mean that anything gets done. So in this system in which we live, you got to put your money where your mouth is. If money or resources don't go to what they're talking about, then it's all just talk, okay? And that goes across all institutions, whether you're in business, whether you're in government, whether you're in education, you can talk about it and we know the problem. But if you don't put your money there, because we live in this capitalist system, if you don't put your money in it, then you won't be able to address the issue, to be honest. And so I think it is a combination of the governmental funding, but also private funders as well, stepping up, putting money into the community. I think we also have to look at, obviously from a national perspective, it's important, but your local institutions, you can do a lot more locally than you can nationally. And so I think that you should, wherever your community is, you do what you can. And I think that's something that we all can do. But then there's also opportunities, and they will come, where you can sort of shift at least a little bit from a national lens. But a lot of things things happen locally. And so that's what I would say is, the government talks a great talk, but certainly when they put their money where they're talking, then you can say, okay, but you can't always, it's just like this stimulus package. Like, there's been great talk, right? But it's all about the money ultimately, and whether, and how much people get it, it boils down to the money, because we certainly live in this, in a capitalist system. So that's how I want to respond to that question.
I had a quick follow-up question to that. So you talked about like getting government funding and private funding, like putting money back into the community, and like the Northeastern University Global Health Initiative, we have led several fundraisers in the past, and I think that's something that we can always kind of improve on, is like figuring out how do we get this redistribution of wealth to happen as effectively and as productively as possible. So I was wondering if you just have any like personal advice for our organization going forward in our fundraising efforts.
Yeah, I think it boils down to collaboration. People like to donate to things that, that it seems like from a donor's perspective, it's all about them actually having the visibility, right? So the more people that they can sort of donate to, the better. And so just from experience from us, so I am sort of director of a coalition of Black churches in San Francisco. Sorry about this. And so we've partnered with about 7 other organizations. And that is really the reason why we're able to, we've received $1.9 million from a private donor to spend for 6 months. And that's on top of other donors. And the reason why is because we knew that you can't work in isolation, that you got to work together. And we were able to sell to them that not only are we working as a collaboration of churches, but we're working with these entities to address food security. And I think that was the sort of the thing that they needed to fund us. So certainly don't do things in isolation, that you go into community, build relationships, and don't always anticipate having funding, on your first ask, but keep asking. But there are foundations that their responsibility is to provide donations, to give out money. And so I think when you partner with folks and build relationships through time, folks will, they'll give.
Thank you for that. And I think we have time for one more question. Does anyone else have?
I had a question. I was kind of really interested in your last point about local versus federal funding, and I'm currently taking a class right now that's talking about healthcare policy, and we were talking a lot about how healthcare spending has gone up so much in the federal government in the last 30, 40 years. So I was kind of but health outcomes, especially for Black people, haven't gone up to the degree that we would like to see. So I was kind of wondering what you think would be a better allocation of resources, because there's so much money already in circulation. How can the federal government better allocate those resources?
This is a great question. So what I'm going to say is you have to always think about, in terms of, the way I think about things is there is this sense, and I can't be for sure, but when we talk about institutional racism, there are people will provide you money, but only for a year to do the work that takes 10 years to do, right? And I think it's sometimes you think, because that happens, that it's designed that way, that we get, so I want to talk about financial sustainability for organizations that are actually doing this work. And sometimes you have to think about how there could be a system in place to prevent that. So if you're only getting, for example, our soda tax work, for example, grantees are only getting money for about 3 to 5 years. Well, do you think that you can change one's health outcomes in 3 to 5 years? Absolutely not. Especially when you're only getting $1 when you need 10, right? And so, so I think what's helpful is that these private public funds fund organizations that are doing the work for long periods of time. I mean, it has taken more than 600 years to get us to this point for Black people. It's gonna certainly take us more than 5 years to get us out. And so when you have funders that only provide assistance temporarily, then you end up actually putting the community as a disadvantage, because that funding only gets you to a certain place. And it really just, most of the funding has to go to people to actually do the work, and you're not able to actually do the work because you don't have enough funding. So I think, I think that a system, this institutionalized, this system perpetuates sort of this continuum of bad health outcomes because of this sort of temporary, sort of putting a Band-Aid over instead of actually healing the wound type of approach in terms of funding. So, we have you all to fight for us, fight for, understand that a lot of things that we deal with are systemic, that they are, it really can be boiled down to this racism, if we call it out, and how it sort of perpetuates into our systems and creates this narrative that oh, we're putting money into organizations, but it's not sustainable. And therefore, you know, people are back to where they were when they started.
Thank you so much for that response. I'm going to stop recording.